morning. Um, the topic today will be suicide prevention. My name is Dr. Agila C. I'm Assistant Professor, Department of Psychiatry, Sri Lakshmana Institute of Medical Science, Bangor, Chennai. And here we have different strategies for suicide prevention. We'll be discussing one by one. Now, why it is difficult? Why suicide prevention by itself is difficult? Because suicide prevention strategies that focus primarily on psychiatric case finding and detection, treatment of depression, and we have supporting high risks, then hence these are inadequate efforts to reduce the suicide in general population. Or no matter what we do, no matter how much we try and do like a qualitative research or a small group discussion or focus group discussion, so many things there are so many studies and trials and so many efforts from the psychiatrists have been put in, despite there is not much of success as expected. So that is the reason it's first of all difficult. And here we have the importance of suicidal behavior to mental health policy. So, what is the mental health policy? That is the importance of suicidal behavior. That is the preventable mortality, operation of psychiatry and medicine, linkage of mental health with community experience, social and economic context, and influenced by various health and welfare related policies. So, now here you can see that there has been a major major breakthrough in the latest National Mental Health Act, that is which came out in June 2017, in which there was decriminalization of suicide. So here you can see the importance of suicidal behavior is preventable mortality, operation of psychiatry and medicine, and linkage of mental health with community experience, social and economic context, influenced by various health and welfare policies. Now, approaches to prevention by the WHO, the World Health Organization, has also they have put a tremendous effort in trying to control and help people who are suffering from depression and prevent suicide. Now, how are they doing it? Actually, they have tried to treat the mental illness, gun possession control, detoxification of domestic gases in case of poisoning, detoxification of car emissions, control of availability of toxic substances, toning down of reports of suicide in media. Now, you just open the newspaper and you get all these suicide. Pictures. Now the media is so going frenzy that it is showing all the pictures and videos of the person who has committed suicide, and it is very pathetic that all these could be easily avoided to the public, to the general public, because it's very disturbing. And we have heard lots of cases of copycat suicide. So these things, especially the last one, is what should be um, imposed by the government, because it is the most um, important right now. So here we have illness accounted for 22.3% of suicides in India. The first is the illness, that is the mental illness, family problems, other causes, drug abuse, then dowry dispute, which is 2.6. This happens only in our country. So 2.6 dowry disputes, poverty, and then there is bankruptcy and sudden economic changes. Financial crisis is one of the biggest causes of depression and suicide. Love affairs, causes not known, unknown deaths, unknown suicides. Other causes 25%, family problems, and then mental illness. So the highest stands the family, other causes, which are like it could be just anything basically. So the family problem stands next, and then next the mental illness. And here we have what important things you would like to do. So the first thing what we would do is the assessment. Definitely, when we have some clues, we have to first assess the person, common warning signs, and identify the mental illness. Of course, after assessing, um, we get the idea about the mental illness, and then we have the um, treatment plan for that. But before that, even there is common warning signs which are most often missed, or most often it is usually ignored by the family members and also even friends and relatives. Now, the worst thing is it's ignored by the family members. Now, that's quite disheartening, but it is easily identifiable, and that's why the word common has been used. So the common warning signs. Now let's go to the common warning signs. That is a change in the behavior, social withdrawal, isolation, loss of resources, less involvement in interests and activities, increased risk taking, and heavy use of alcohol or drugs. Physical conditions, if you can see the abrupt changes in the appearance and recent weight or appetite change. And here we have the sleeplessness or sleepiness, lethargy, and exhaustion. Now, here we have the behavioral changes. Usually, a normal person getting isolated and for no reason, and there is just loss of resources, and he's not interested in the activities he previously was. No, man, I'm fine. I don't want to join you for the movie, or I don't want to go have dinner with you guys. I'm sorry, something is wrong. So, increased risk taking involving in alcohol and drugs and like rash driving, these are all these are all a sudden change in the behavior of a person who used to be very normal in accordance to the normalcy of the population. Now, all these are definitely changes in behavior. Now, these can be picked up by anyone. A person need not be a psychiatrist to do this. Now, like I mentioned, it is like it's a very common thing. It is like why these things are missed out. It's such a clueless thing. Like why people are missing out even today. All these warning signs. Now, that's a big surprise or shock as a psychiatrist for me, because we have heard so many stories like all of a sudden this person committed suicide. Now, how? Now, without any warning signs, the person cannot, unless and until it's an impulsive act of suicide. So that is how maybe we are ignoring the deeper part of the iceberg. And then there is a physical condition, there is the abrupt changes in the appearance and recent weight or appetite change. There could be a weight loss. Now, in depression, we have mostly weight loss or weight gain. Now, in weight gain, you can easily identify if the person is a person can gain weight in normal ways as well. That is okay. But there is something related to the mood always. So you can just guess by the weight loss and appetite change. They don't eat as they used to. Sleeplessness and sleepiness, it could be both ways. And then there is lethargy and exhaustion. They're always dull and tired. So these are the very very common signs which are not to be ignored. And thoughts, so what are the thoughts usually? Now they get inability, they have the feeling of inability to concentrate or think rationally, exaggerated fears of the disease, low self-esteem, feeling of hopelessness or helplessness, increased irritability or anger, or extreme anxiety and stress and intolerable loss. Now, here we have thoughts. Now, thoughts are usually irrational and exaggerated fears of disease. Like it could be just any fear, like basic fear. And there is low self esteem, which is the first and foremost thing we have to look for in even in depression. Uh, Low self-esteem could have been a part of the personality as well. It need not just pop up recently, or it need not just become a common warning sign as such. It could have been a part of personality, the trait and temperament, and feeling of hopelessness or helplessness is and worthlessness is a common triad of depression. Now, Beck's cognitive triad, if you can recollect. Now, these are the feelings. Then there is irritability and anger outbursts for no reason. There is extreme anxiety. And then there is stress, that is intolerable loss. Like there is extreme stress. And Here we have the indicators of risk. Now, what are the indicators? Now, thoughts of suicides are particularly the thoughts of suicide. That is, those are particular are particularly strong indicator of potential suicide. Now, there is a difference between the death wish and the suicidal idea. Now, what is a death wish? Death wish is I'd rather be dead instead of living this life which has no meaning. I'd rather be dead. I'd rather be dead instead of suffering from this illness. I'd rather be dead instead of going for this work. So I would rather be dead means I wish I was dead, or it is just a wish. It's a death wish. Now, how does it? How is it different from a suicidal idea? A suicidal idea is something which is very strong, which is deep rooted, and which has got the real intention. And it may be high or low intent, it may be high risk or low risk, but still there is a strong intention. I want to die, I'm willing to die, I'm willing to end my life. Now these are the words, exact words. Even when they are often stated in a roundabout way. Often these thoughts are not directly or openly expressed. Find out if a person is thinking about suicide, ask directly. Now that is what we do. Like either ways, it's just beat around the bush for these people. So here we cannot beat around the bush as psychiatrists. We have to directly question them like a close-ended question, and it should be very clear that what is in your mind. I mean, don't have to hide. You don't have to hide the truth. What exactly are you thinking? So these are the things that should be, not omitted. Like it should be kept in mind, and the person should always be asked in a straightforward manner. I mean, if you feel that you should not ask about suicide now, that may, trigger thoughts in him of suicide and all those things. No, that is not the way of approach in suicide. Okay, here we have all the rights and we have all the authority to go ahead with the questions. That is perfect close-ended questions. Then we have the indicators of risk, like we've discussed. That is stress. Intolerable stress comes from developmental or situational events and often personal losses which have a crisis impact on an individual. Example include rape or sexual abuse, suicide or other death of a parent, child, spouse, or loved one, separation or divorce, serious illness or substance abuse by someone close. So these are all the biggest indicators. Now you can see the last line here. Now you might have heard something about post-traumatic stress disorder, where you have these. The person can be the one who directly experienced the trauma, or he or she can be the direct witness, like in Gulf War, which where it started for the first time. Now PTSD can also be a cause basically, because for example you can see the suicide or death of a parent, child, spouse. Just imagine the amount of trauma. Now these people can just imitate like a copycat suicide, or it could be maybe due to the direct trauma like rape, like the person who suffers from the direct trauma. That also could be one of the reasons. And now here we have the substance abuse or by someone close. Now, what is substance abuse? Because here we have substance abuse that could be mostly alcohol. Then we have opioid. Then we have cannabis. Now, substance abuse is directly correlated with many of the suicide attempts, alcohol intoxication, and opioid intoxication, so many things. So here we have substance and sexual abuse and death of a closed one as a prime factor. That is, these are the indicators of risk. Now you should have a close watch on them. Now there's nothing wrong in asking them, do you have such thoughts? There's nothing wrong, because it's okay, it's just fine. So it's better to ask rather than not to. So it's better to ask. So here we have the assessment of risk level. What is at present in patient's mind? Was it before also? What are the possible support system? Is there any mental illness, high, moderate, low? So what is present in the patient's mind? See, here we have a huge question. Now this is totally an open-ended question. Like what is there in your mind? Now we are not closing the question with do you have suicidal thoughts? Yes or no? No, it's not like that. What is present? It could be anything. It could be just a small fight with a sibling, or it could be a love affair, or it could be a death of a close friend. Now, what is there in your mind? Now, those are the first questions that should come to that person by anyone, not just a psychiatrist. That's why I'm again warning. It's not just the duty of ours, it's also the duty of the relatives, the friends, the family members, whoever it is. I mean, even you can assess the risk level. Now, why it is always till the last moment you have to wait? Now, we had cases where there were multiple attempts, and then there was never an intervention done for that person. I remember so clearly. Um, one of our friends from the undergraduate class, like that person's parents were doctors, and he had attempted 7 times, and no intervention was done. So I was wondering, like, how can educated parents, I mean, both are doctors, and if they can do that, then I can imagine the regular population. Because, okay, I don't want to generalize, but this is a big blunder or a big unforgivable mistake which has costed a life. So how can someone not intervene? How can a father or a mother or a sister not intervene, or a friend not intervene after 7 attempts? Now, this is just an example I'm telling you because this really disturbed and affected, it created a wave on all of us because that was the first ever direct witness of a suicide that we had seen in our undergraduate time, and it was so disturbing. Now, so many times we tried to communicate, but it was all in vain. But still, things could have been better. He could have been alive today. So, was it before also? Of course, it could have been. Now, that we are not aware, it could have been. What are the possible support systems? Now, support systems are the first support system is always parents. Now, when the parents are problematic, where will he go? He or she go to the friends. Now, that is a second level. Then, if friends are the ones who he is daily meeting or who she is daily meeting, okay, they are less in number. Fine, they cannot give the time. Then, who's the third level? That's the relatives. Or we can put the relatives in the second level, and the third level would be the friends, and fourth level will be the peers, right? The peers who are working with them, colleagues. So this is now we are going to segregate, or we are going to tire it. Like we are giving different tires: first level, second level, third level, and fourth level. First level is always the parents and siblings. Now, second level will be the relatives and cousins. The third level will be the friends or the peers or the colleagues, or the fourth level will be the peers or colleagues. Now, these are the possible support systems. Now, whenever you have a friend or whenever someone is just, going through a phase, we cannot just stop there. We cannot just, uh, tell them, okay, let's just go for a movie, let's just have dinner. No, they're not going to come with you. It's just the support system. The support system, we we all we all can do this much by finding the person's support system. If you're not the support system, at least find the person's support system. Now, is there any mental illness? That's the last one. Of course, depression, schizophrenia, mania, Bipolar 2 has a very high suicidality, also schizophrenia, also depression. So all these things, and also heavy correlation with substance abuse, like we mentioned in the beginning. So all these things are going to play a major role. Now here we have the different um, categories of the severity. That is a high, moderate, low. Now, why is this important? Why we have mentioned as high, moderate, low? Because in high, it is usually correlating, like it's directly proportional to the risk of suicide. In moderate, again, we cannot say it's directly proportional. It can be indirectly proportional. It can go to the higher end, and that same applies to the low. Okay? So the low, definitely we cannot ignore. So any mental illness we are not ignoring. And that's why we've given different categories. So we cannot ignore. An assessment of risk level, what is present in the patient? Suicide plan. Okay. The first thing I forgot to talk about is suicide plan. What is in the patient's mind is fine, but is there any plan? Readiness to carry out the plan, time frame, work for completing the act. Can you probe skillfully? Most people will openly and honestly share the details of the plan because there's nothing to hide. Now, if they just want to die, um, it's not like you can just keep the people around him on 24/7 CCTV camera and all these things. We can't just do that. If the person has decided, if he's very strong, and if the intentions are strong, nothing can be done, right? But at least we can lend a helping ear. We can lend a helping hand by actually listening to him, by treating him, by bringing him to the indoor setup of psychiatry ward, and maybe ECT is going to work out because the person is having a ready-made plan. Like he has a readiness to carry out the plan and a time frame work for completing the act. He's so clear. Definitely, this sort of person needs an indoor treatment. And or if the person is not willing, then we have to inform the relatives. Now, this is something very serious. Now, assess this is high risk level. This is the highest. That is readiness to carry out the plan and a time frame work for completing the act. This is like the highest. So, can you probe skillfully? Even the psychiatrist, uh, to be skillful, it takes a lot of experience, and some people may not tell. Basically, many people may open up, but some people may not say, and the next day they may not be there. So skillful. That's why the word skillful has been used. So that is our, you know, uh, maybe we can say talent. So assessment of risk, was it there before also? So people who had previously tried to kill themselves are 40 times more at risk of suicide than someone has never tried before. That is, people who have previously tried to kill themselves are at 40 times more risk of suicide than someone who's never tried before. Okay, so it is like you can just imagine the example of that person. 7 attempts, 7 into 40, that makes it 280 times than the normal person. So that is how strong it was. So I'm just giving you the magnitude of the suicidal intention. A prior attempt may indicate the individual's acceptance of suicide as an alternative to life. Like again I said, an attempt indicates the individual's acceptance of suicide as an alternative to life. Then now here we have the patients at high risk of suicidal behavior, divorced, widowed, or single status, living alone, socially isolated, unemployed, retired, bereavement in childhood, and if the patient is under psychiatric treatment, the risk is higher in those who have recently been discharged from the hospital, those who have made previous suicide attempts. Now you can see. like divorced, widowed, and or single status. Divorce is like okay, they can cope up, but widowed, yes, or single status. Single status also sometimes bring in a lot of worthlessness or low self-esteem or hopelessness and living alone, socially isolated, always in the isolated area, unemployed or retired. Now both are the extremes, like either unemployment or retirement. Like retirement may not be like in the top of the causes, but it can be one of the causes when the person was the only breadwinner of the family and daughters are all married off and now there's no job and because of the latest no pension scheme and all, they might be suffering from a lot of financial crisis. So that could be one cause. And bereavement in childhood, that is death of the close one witnessed by the child. And so, these are all very big things. And here we have the risk is higher in people who are just discharged from hospital after a good treatment of suicidal ideas. Once they go there, there can be a chance of a sudden impulsive outburst, which can lead to completed suicide. Now, this is one thing uh, very challenging because okay, you feel okay, we've given ECPs and we have like totally completely cured the patient, like cured. That's how we think. So we have done our best for the patient. Okay, patient is now discharged, fine and everything. And then 3 months later, we get a news from the parents that he's no more. So that is because, or not 3 months actually. Like I'm talking about the real case scenario once we had a patient, but here we are talking about recently discharged because see again now there's one drug called fluoxetine which has a black box warning. The patient on fluoxetine for suicidal ideas goes home and then after discharge goes home and takes the medication, is on regular medication. One fine morning, he's found to be hanging himself, and fluoxetine has got the black box warning on its box. So it is very important to look into all these things. And those who have made previous suicide attempts, like I mentioned, a patient at high risk of suicidal behavior, that is, in addition to life stressor, um, associated with increased risk of suicide include marital separation, bereavement, and family disturbances, change in occupational or financial status, rejection by a significant person, shame and threat of being found guilty. So, in addition to recent life stresses with increased risk of suicide include first is marital separation, bereavement, and family disturbances, change in occupation or financial status, rejection by a significant person, shame and threat of being found guilty. Now, how do we manage these suicidal patients? The problem of the feelings of the suicidal person are usually a triad of helplessness, hopelessness, and despair. The three most common states are the ambivalence. Now, the majority of suicidal patients are ambivalent till the very end. There is a seesaw battle between the wish to live and wish to die. Now, again, here it's only death wish type. Now, ambivalence is still not suicidal ideas. Okay, if the ambivalence is used by the physician as a key, now we can use this as a key to increase the wish to live, and suicidal risk may be reduced. Now, next comes the impulsivity. Impulsivity is a suicide is an impulsive phenomenon. An impulse, by its very nature, is transient. If support is provided at the moment of impulse, the crisis may be diffused. And here, the rigidity, that is, suicidal people are constricted in their thinking, mood, action, and their reasoning is dichotomized in terms of either or. Either or. By exploring several possible alternatives to death with the suicidal patient, the physician gently makes the patient realize that there are other options, even if they are not ideal. So suicidal people are constricted in their mind, thinking, mood, and action, and their reasoning is dichotomized. So this is how we think about the rigidity. Now, by exploring several possible alternatives to death with suicidal patient, the physician gently makes the patient realize that there are other options. And suicide and mental disorders, we have suicide and depression. These are closely linked. 45 to 70% of suicidal cases, that is, depressive disorders was the cause, and hopelessness and helplessness are one thing. Then we have schizophrenia, specific risk factors. Suicide is the largest single cause of premature death among schizophrenics, young, unemployed, male, recurrent relapses. Then we have fear of deterioration, especially in those with high intellectual ability. And we have positive symptoms of suspiciousness and delusions, and depressive symptoms, early stages of illness, and family problems. So here we can see suicide is the largest single cause of premature death among schizophrenia. Alcohol and suicide, like I said, again, disinhibiting effects and relationship effects. And then we have the hostility. So here we have the disinhibiting effects and the relationship loss and hostility. And then we have okay, alcohol uses three ways. Okay, so then we have the, I'm sorry, suicide and physical disorders, that is the increased rate of psychiatric disorders, especially depression, chronic and disability, and negative prognosis. Epilepsy has been associated with increased suicide, terminal illness, pain, and HIV infection and AIDS. Then personality disorders and suicide are high prevalence, 20 to 50% of personality disorder in young people who committed suicide. More frequently associated with suicide are borderline personality, antisocial personality disorders, histrionic and narcissistic personality disorders. Certain psychological traits such as impulsivity and aggression have also been associated with suicide. How to help so that immediate danger is prevented? Now, how would you involve the patient? How to identify suicidal behavior? Find out reasons, assess the risk, therapeutic contract, and follow up. So, how would you involve the patient? How to identify suicidal behavior, find out reasons, assess risk, and therapeutic contract, and follow up. Key intervention tasks, that is, involve the client in dialogue that focus on feeling about disruptive life events and emotional social reaction to these events. Now, key intervention tasks involve the client in dialogue that focuses on feeling about disruptive life events and emotional social reaction to these events, sense of acceptance, open expression of this personal concerns, and use expressive skills. Now, identify the person is thinking about suicide, symptom of stresses, various expressions of suicide intent, conversation towards the question of suicide, direct and to the point. And find out about the person, about the reasons why these events, why these feelings, fuller understanding that a therapist client together about suicide, understand the ambivalence. Then assess the level of risk for suicide and check to see if the person agrees with your assessment. To summarize your present understanding, how it is planned, how prepared, and timing. Then we have the contract, that is the agreement with the plan of action, which includes no self-harm contract to reduce the immediate risk, share your observation, introduce other solutions, mutuality, and commitment. Now, follow-up is one key here. By doing what you committed to, only make commitments that you can and you want to complete, not too much. Only commitments that you want to do. Involvement is commitment to say that he's not alone. Suicide prevention in adolescents. The primary prevention is identify the high-risk groups, intervene before the suicide behavior, mental health education, and school mental health programs, and identify the mental illness. Secondary prevention is early diagnosis, prompt treatment, individual counseling, supportive and family therapy, drug treatment as per assessment ECT. Tertiary prevention is caring for the attempters, their family, risk of repeat attempt, contagion factor that is copycat, like I mentioned, parents, spouse, teachers, mental health professionals to work together, role of NGOs and helplines. What can you do to support? The physician should assess the available support system, that is emotional, to build the emotional rapport, and also the rapport building, emotional support and the rapport building. Identify a relative friend who would be supportive to the patient, solicit the key person's help, make relatives your co-therapist at workplace and at home. What can you do? Support an action plan. The focus of the support should be providing hope, encouraging dependence, help to cope up with life stresses, reassurance, close monitoring, combat social isolation. Now, these are the resources to be used. External resources may consist family and friends, financial security, satisfying job, a place to live, and membership to or access to helpful contacts. Now, what can you do? Contracting, entering into a no suicide contract. Now, no suicide contract, like we can have this contract as a useful technique in the suicide prevention. Now, suicide risk identification, assessment, and plan of action. Now, you can see zero, no distress, no need assessment, no action needed. Emotionally disturbed, inquire about suicidal thoughts, listen with empathy. Then, two, vague ideas of death, inquire about suicidal thoughts and listen with empathy. Three, vague suicidal thoughts, assess the intent, that is plan and method, explore the possibilities and identify support. Then four, suicidal ideas but no psychiatric disorder, assess the intent, plan and method, explore possibilities and identify support. Now, suicidal ideas and psychiatric disorders, severe life stresses, assess the intent, plan and make a contract. That is biggest thing referred to a psychiatrist. Now, the next one is suicidal ideas, psychiatric disorders, severe life stresses, agitation, previous attempt. Stay with the patient to prevent access to means, hospitalize, and ECT. Offer hope, prevent suicide. Thank you so much for this opportunity. I thank you a lot once again. Let's do this together to prevent suicide. Thank you.